speakers. The first session is very much in that arena of experience, decision making, and the important stuff that really makes a difference in clinical care. So we have some recordings, but Anna Davies is able to join us. She's a psychologist. I'm sure she can tell us more about her credentials, but also an up-and-coming superstar, and absolutely delighted she's interested in this area. And I think she's got some of her colleagues, Asifa, who I think has got some sort of public patient experience in this area. Anna, over to you.
Thanks very much, Andrew. I'll just share my slides. Is that all displaying? Is that working as expected?
Yeah, that's great.
Great, thank you. Well, thank you very much for the introduction, Andrew. Yes, I'm Anna Davies, and I'm joined here today by Asifa Hameed, and we're going to talk today about a project we've been doing here in Bristol to try and move some research findings as quickly as possible into practice. So it's a joint talk today. I'm going to start by introducing some of the studies that underpin this co-production project. I'm going to talk a bit about the co-design process, and then I'm going to hand over to Asifa, who's going to tell you a little bit about her experiences of being recommended aspirin and the outcome of our co-design work. And then we'll discuss a little bit of our dissemination plans also. So I'm sure I don't need to tell this group that we know that low-dose aspirin is one of the key tools that we have to try and prevent pre-eclampsia. But if people are not taking it as expected, it may reduce its benefits. And we know from the evidence that between 40 and 60% of women report non-adherence to it. And by that, I mean not taking it as often as is recommended or not taking it at all. We know from the data as well that underserved women are less likely to take it, and more generally that they have poorer pregnancy outcomes from the EMBRACE reports. In our research team, we've undertaken a systematic review of interventions looking at how to support medication adherence more broadly across pregnancy, and found only one study that targeted aspirin adherence. It was carried out in India. So what we wanted to do was look at the barriers and facilitators to taking low-dose aspirin to try and inform an adherence intervention. So to do this, we carried out two qualitative interview studies. The first looked at barriers and facilitators in a population where we recruited women from antenatal clinics. You can see here on the left that we recruited women who were predominantly white British and were fairly highly educated. So what we did is replicate that study again in a group of women and achieve some funding to carry it out again in underserved groups. And we recruited this group of women slightly differently. We went out to the community and worked with a community healthcare organisation, used social media and word of mouth. And we were successful in recruiting a broad range of women from different ethnic groups. A number of them were born outside of the UK. Also, a good proportion of them had minimal or no educational qualifications, and 4 of them self-identified as being from low-income groups. So this really was a group of people that we don't typically see in our research. We purposefully sampled to ensure that we represented a range of adherence patterns. So some women who were non-adherent and weren't taking any at all, some who were taking fewer than 5 doses a week, and 4 who were taking it as was recommended. The findings of the first study have been published in BMC Pregnancy and Childbirth, and we're just writing up the second. So I've actually presented some of the findings from this research before, but I wanted to touch on the key points that sort of led to this second bit of research and the co-design. And the first point that we found across both of these studies was that women didn't really understand that they had a risk of pre-eclampsia. There was real variation in women's understanding of what their risk factors were. Where women did have an understanding of their risk factors, they didn't necessarily identify with them. So some of the women who've been recommended it due to high BMI didn't identify with that. A lot of the women didn't understand that a risk assessment had even taken place. We did find that women who had previous experience of placental risk were more aware of the reasons for recommendation, and that was their own risk or perhaps a family member, their mother or their sister. We also found that women used information from their healthcare appointments to understand their risk. So women called upon information about their urine dips, their blood pressure checks, and also scans looking at the baby's growth to understand whether they had a risk. And if those were going well, they thought that that meant they didn't need to take low-dose aspirin. We also found that women didn't particularly see pre-eclampsia or placental dysfunction as risky. They had very limited knowledge of pre-eclampsia and what it could mean for them. And where they did have some knowledge about it, they particularly were focused on problems for them and were quite unaware of the potential impacts for their baby. What we also found was that women didn't feel particularly susceptible to severe consequences of pre-eclampsia. So they thought that the monitoring that they were having and the care that they would receive would mean that they could avert those serious problems. I also wanted to highlight one of the key issues that we found, which was the important role of the conversation with healthcare professionals. So women described that they had very little information, the conversations that they had were very brief, and none of the women across either of the studies were given any information to take home, and nor were they referred to any online resources. Women also reported that they were never asked again about taking low-dose aspirin in a subsequent appointment. And where women did discuss it and mentioned that they weren't taking it, this wasn't then pursued within the conversation. A lot of the women also reported to us that when they had questions or concerns, the healthcare professional they were talking to seemed unable to answer their questions. I want to highlight now some of the themes that were specific to the underserved group, so those women in the second study. And one of the key things I think it's important to highlight is that there was a perceived racial bias in the recommendation. We've got this really important quote over here on the right-hand side, where a woman said she attended a mother and baby group, asked the other mothers whether they had been recommended it. And she identified that all the women from ethnic minority groups were taking it, but the white women weren't. And she was questioning what that meant for her. And this was sort of coupled with a general feeling of being unsafe in the care environment. We were carrying out this research at the point when there was a lot of attention on the Embrace reports. Women in this group had more aspirin safety concerns, particularly since some of them had had family experiences of adverse reactions to low-dose aspirin. And the other thing I wanted to point out, that this group were very active in seeking information about taking low-dose aspirin. They went online, they tried to read up on it, and they also sought the views of their family members and friends in trying to inform their decision. So what does this mean? So I think this highlights to us the importance of giving women high quality information and addressing their informational needs. Women are not passive recipients of this recommendation, and they do want to understand what they're taking and why they're taking it before they make a choice to do something that they are concerned may be harmful to their baby. I think we need to improve the way that we're communicating with women about the risk assessment, but I do appreciate that we need to understand the staff's experience of providing this aspect of care in terms of the fact that it has to happen in a very busy antenatal clinic environment. I think what we need to do is think about how we deliver this information in an acceptable format, in a way that women will trust and that appeals to a broad range of socio-demographic groups. So this really lends itself to a co-design approach. So what we've been doing here in Bristol is co-designing an information video and leaflet. We got a small grant from the University of Bristol Participatory Research Fund to support its development. We landed on a video and a leaflet, and what we wanted to do was use the words and the voices of ordinary women to make it appealing. With the aim that we would be able to share it on our NHS maternity clinic TVs, but also we are able to share it via the Badger app, which is in use in both trusts in Bristol. The aim was also to translate it into other languages, and I want to highlight that it's important that we voice over these videos in other languages, because a number of women have told us that they don't read or write in their own language, particularly women who I've spoken to who speak Urdu and Punjabi. And we want to make sure that this gets out in the world via social media, as more and more women are using things like TikTok to access maternity information. And just to highlight that the project was supported by APEC. So our co-design group involved 10 postnatal and pregnant women who we recruited with support from AFI Health, who are a community healthcare organisation serving women in underserved areas of Bristol. We achieved diverse recruitment, a range of women from different ethnic groups and social groups as well. 8 of the women spoke an additional language to English. We made sure that these meetings were accessible to women with small children. So we had some preschoolers and babies at our meetings. And I also wanted to highlight that these women did describe some really challenging pre-eclampsia experiences around having symptoms of it that weren't picked up. And also, sadly, one lady lost her baby. So this was the process of the co-design. We had 6 workshops where we met in person. In the first meeting, we introduced the group to each other and asked women to tell us what their questions and concerns were that they had about aspirin. And we used this to do a prioritization exercise where we asked them to identify what they thought was absolutely vital information to go into the video and leaflet, and what information we could look for online and refer women to. We then used that prioritization work to write the scripts for the video, and we passed those to 2 senior obstetricians and to APEC for fact checking and to ensure it was accurate. And then we worked with the graphic design team to look at and think about the design of the characters, making sure there was representation of a range of different ethnic and demographic groups. We wanted to think about the feel and the music and make sure that it appealed to women. We then had a 5th workshop where 7 of the participants came forward and wanted to record their voices. And this was supported by Medical Illustration at University Hospitals Bristol, who've done an amazing job. In the 6th workshop, we got together with the participants, and they brought their family members, and also the funders attended, and we held a celebration lunch and did a screening of the video. And since we've had that workshop, we've been working on translation. So it's been recorded so far in Arabic and Urdu by 2 members of the community who are able to translate. And we've been working on the development of the leaflet. We've also then taken our video out to a big dissemination event in Bristol. So 3 of the co-design team came to a public science event that the University of Bristol hold at Bristol's Science Museum, which is called We the Curious. And it was attended by over 300 families from deprived areas of Bristol. So what I'm hoping to do, and hope will go well now, is hand over to Asifa. She's going to tell us a little bit about why she wanted to join this project, and she's going to also then introduce the video for us. So hopefully, Asifa, you're here and ready to talk.
Hi, good morning. Can you hear me, Anna? Hi, I'm one of the mothers who took the study with Anna. I've got 4 kids, and I learned about this study through a local WhatsApp group for Muslim mamas in Bristol. The reason why it caught my attention, because I didn't have a great experience with taking aspirin or being prescribed aspirin during my last pregnancy, my 4th pregnancy. And I just really wanted to know more about it, about aspirin. I felt like there were a lot of questions not being answered through the midwife. And like Anna said, I had to constantly go back to the NHS website, go to the internet to find any information to help me decide about taking the aspirin. So what happened in my 4th pregnancy, in my first appointment with my midwife, the midwife gave me 4 packs of aspirin. And she told me I need to drink 2 tablets every day for 9 months. Now, I did mention to the midwife that I was not comfortable with taking aspirin for that very long time, highlighting the fact that I had 3 previous pregnancies, had no health issues, have no history in my family even having pre-eclampsia or being prescribed aspirin, including my mother, who had 6 children, including a twin pregnancy. But I don't think the midwife was really taking any of that. And she's like, yeah, you just, you out of a black minority, and, we need to make sure that to reduce the risk for pre-eclampsia. And I was like, but why do I have to take 2 tablets and for 9 months? Why can I not, for example, take this in the last part of my pregnancy? And she was like, oh, this is the guidelines. And that was it. And she didn't give me really any other answers, and she didn't follow up in the subsequent appointments. So that put me really on edge, and I was not comfortable drinking something, especially that if it was just me, but because I had the baby inside me, I felt I had the responsibility of knowing what I put inside my, what I put inside my body, because I'm also now responsible for a baby. So I didn't end up taking the aspirin. And I did have a healthy pregnancy, and I did have a healthy birth, just like the previous ones. But I always had the question, why did this happen? Why was I not explained to me accurately? Why was it important to take aspirin? Why was I of a high risk? Why is it because also of my age? Because I was 36 years old at that time. So there was a lot of questions that I didn't quite understand. And through the study with Anna, it was really good to learn more about aspirin and the links to pre-eclampsia, and just to get to educate myself and educate the people around me, whether the friends, family, just to get to know more about it, because I didn't get that support from my midwife or from the medical staff I met, and I never found the answers I wanted to know. So that study really helped me a lot through the workshops. It was really nice to put together the leaflet that we put together with all the information that would have been helpful for me if I have read it at the time when I was having all these questions in my head. And also the video that later on we have me and the other mothers, with the help of Anna and other members, to put together that video. And with no further ado, I'm pleased to present to you the video. Thank you.
Thanks, Asifa. So I'm just mindful of time, so we're going to play a little bit of the video.
This video explains what pre-eclampsia is and why you may be recommended low-dose aspirin during your pregnancy to prevent it.
Pre-eclampsia affects nearly 35,000 pregnant women in the UK every year, usually after 20 weeks of pregnancy. The main signs of pre-eclampsia are high blood pressure and protein in your urine.
Pre-eclampsia can reduce the amount of oxygen and nutrition reaching your baby. This can affect their growth and make your baby unwell. Very rarely, it can mean that a baby dies before or soon after it is born. In a small number of cases, and if not treated, pre-eclampsia could develop into eclampsia. This causes serious complications for mum, including fits and stopping her organs from working properly, such as the liver or kidneys. It's important for us to diagnose and treat pre-eclampsia as soon as possible to prevent problems. This is why your blood pressure and urine are checked at every appointment. It's important to bring a urine sample if you're unable to do one at your appointment.
You may not get any symptoms at all, but symptoms that can suggest pre-eclampsia include a severe headache that doesn't go away with pain medication, changes in eyesight, such as blurring, flashing, or floaters appearing, swelling of your face, hands, or feet, or severe pain in your upper abdomen. You should always tell your midwife or doctor if you develop any of these symptoms.
Your medical and family history might mean you have an increased chance of getting pre-eclampsia. Early in pregnancy, your midwife will assess your risk.
I'm just going to stop the video there because it goes on for about 3.5 minutes, but we wanted to highlight that this video is available. We can share it in the links in the chat perhaps, and share the link to the online video on YouTube. The video is available currently in English, and then it will be available in Arabic and Urdu, and I've realised I've got the wrong year there. It's going to be available in January 26. A leaflet based on that video is going to be finalised, and then we're very happy to discuss further recordings of it in languages that are spoken locally to you. We really appreciate it if you are interested in seeing the video and hearing more about it and potentially sharing it, that you let us know. You can use this QR code over here on the right just to let us know on a form, and then we can get in touch. It will be helpful for us to use that to evaluate impact of it. And you're very welcome as well to get in touch with us, in touch with me via my email address. So thank you very much for your time this morning, and I'm very happy to answer any questions if there's time.
Thanks, Anna. Unfortunately, we've gone over time, so we better move on. Really great to see work that's related to implementation, because this really matters in terms of, you know, it's all well and good having evidence, but unless people use it, we're going nowhere. So congratulations on this. People may ask questions, and if we've got time, we might come back to you, but we better just move on as we're running over already.
Absolutely fine. Thank you.
Thank you both. That's really great.
Thanks.